Today we're going to be talking about the lower limb anatomy for the FRCR Part 1 exam. We'll start with the hip. The pelvis is made out of three main bones, the ilium, the ischium, and the pubis. These all join together to form the acetabulum. In pediatric patients, you can see something called the triradiate cartilage, which connects all three. The ischium and pubis also have an articulation, and in pediatric cases, you can see it, and it's called the ischiopubic synchondrosis. There are also the ischial tuberosities where the hamstring tendons attach, and this is the bony protuberance which you sit on. There are a few muscles within the leg that you need to be aware of. In the anterior compartment, starting superiorly, you've got the psoas major muscle, which originates from a paraspinal location and joins with the iliacus muscle to create the iliopsoas muscle, the tendon of which attaches to the lesser trochanter of the hip. You then have the sartorius muscle, which starts from the ASIS or anterior superior iliac spine and then comes medially and attaches to the tibia. You then have the quadriceps muscle group. You've got the vastus lateralis, rectus femoris, vastus medialis, and you can't see it, but you've got the vastus intermedius as well. The rectus femoris originates from the anterior inferior iliac spine, or the AISIS. You then have a small anterior hip muscle here called the pectineus muscle. You then have the adductor muscle group muscles. You've got adductor brevis, which is the shortest. You've got adductor longus, which is quite long and slender. And then you've got adductor magnus, which is the largest. There are also short external rotators of the hip. One of them is labeled here, and that's obturator externus. And that attaches to the greater trochanter. All of these originate from the pubis and ischium. These are, again, the anterior thigh muscles, and I've highlighted it here. So you've got the anterior superior iliac spine where the sartorius muscle attaches and then comes medially to attach on the tibia. You then have this muscle here, which has quite a specific look. It's called tensor fascia lata, and it's got a speckled appearance on MRI because of the sort of speckled fat content within it. You then have this, which is your iliotibial band, which attaches laterally. You have, again, your vastus muscles. You've got vastus lateralis, vastus medialis. You've got your rectus femoris, and then the adductor muscle group as well. I didn't mention before, you've got a muscle called gracilis, which is a long, slender muscle, again, on the medial aspect of the thigh, which has a distinct look, and they can test it in the exam quite easily. The quadriceps muscles all join together and then create the quadriceps expansion or quadriceps tendon, which then attaches to the patella, and then the patella attaches to the tibial tuberosity via the patellar ligament. We should call it ligament in the exam, and the patella is a sesamoid bone because it travels through a ligament. This is another cross-sectional schematic. Again, you've got the anterior muscles of the thigh. Medially, you have this muscle, which is your sartorius, which will come and attach to the medial knee. Adductor longus is of a smaller caliber compared to adductor magnus, as you can see here. And the most superficial muscle on the medial side is gracilis. In the posterior compartment, you've got the hamstring muscles as well. These are those hamstring muscles. So proximally, you've got the tendon of the semimembranosus muscle, which attaches to the ischial tuberosity laterally. And then you've also got the conjoint tendon of the semitendinosus and long head of the biceps tendon, biceps femoris muscle, which attaches more medially. You can see here, this is the long head of the biceps femoris muscle. There's also a short head as well. You've got semimembranosus medially, and then you've got semitendinosus here. They do a bit of a swap, but as I mentioned, those tendon attachments on the ischial tuberosity as before, and I'll show it to you. This is them sort of midway down the thigh. You've got your gracilis here, you've got semimembranosus, and then you've got semitendinosus. M is before T, and in the upper thigh, that is the way to remember it. They switch over later on, but in the upper thigh, semimembranosus is more medial to semitendinosus, and then as you can see here, you've got your long head of biceps femoris muscle, and then you've got the short head here. These are the gluteal muscles. This is a posterior view of the thigh. The big muscle, which makes up the majority of the buttock that you can see and feel, is your gluteus maximus muscle. You then have your gluteus medius muscle just deep to that, and deep to that is your gluteus minimus muscle. Over here in the lateral thigh, you can see your tensor fascia lata, and then you've got your hamstring muscle group here as well. So you can see gluteus maximus has been removed, and so you've got gluteus medius here, and then you've got gluteus minimus here, and these attach to the greater trochanter at different facets, which you probably won't need to know for the exam. You then can see that the hamstring muscles attach to the ischial tuberosity, and as I mentioned, the proximal tendon of semimembranosus is lateral, and then the conjoint tendon of semitendinosus and the long head of the biceps femoris muscle are more medial, and that is one tendon that makes the two. These are your short external rotator muscles. They've got distinctive looks. That's your, well, I'll show it to you on the MRI, but that composes of piriformis, the gemellus muscles, which there's a superior and inferior one, your obturator internus and obturator externus, and also something called your quadratus femoris muscle as well. Again, a lateral view, you can see gluteus maximus here, medius there, tensor fascia lata, iliotibial band, and then the other muscles which we've spoken about. This is a cross-sectional view of the hip. The most anterior muscle, remember attaching from the asus, is your sartorius. You then have your iliacus muscle and your psoas muscle. They haven't sort of joined at this point, but that will then come inferiorly and attach to the lesser trochanter of the hip. You then have this, which is your rectus femoris muscle. The rectus femoris muscle has a little bit of tendon here. There are two heads to it, which you won't need to know for the exam, but it means that some of the tendon is actually peripheral at this level. You then have your greater trochanter, which you can see here. Obturatus internus has a distinctive look. It's got this 90-degree look, so it comes from the pelvic sidewall and then comes laterally and attaches to the greater trochanter. Pectineus is this anteriormost muscle here, which has got quite a distinctive look. A little bit further down, again, you can see sartorius, adductor longus, brevis, which has a short attachment and attaches quite high up on the femur. You then have your adductor magnus, gracilis is that gracile, quite small muscle in the medial thigh, and then the other muscles which we've spoken about. Further down in the thigh, this is your vastus intermedius. That is the quadriceps muscle which wraps around the femur, and it's got quite a distinctive look. Vastus lateralis, vastus medialis, and rectus femoris, those make up your quadriceps muscles. We've spoken about the adductor muscles. You've got gracilis there. Remember, membranosus is more medial to tendinosus in the upper thigh. And then you've got your biceps femoris muscles, the long head and the short head here. We can go through some MRI now, just to sort of reinforce those points. Starting quite high up, you've got this muscle, your psoas major muscle, which comes down, and with the iliacus muscle, forms the psoas major muscle, and then this is the tendon here, and that attaches to the lesser trochanter. You then have your sartorius muscle here, which attaches to the asus, and then that comes all the way down, if we follow it, here, in the medial leg, and then attaches with the pes anseriens tendons on the tibia. The next muscle was rectus femoris, which they can test. This is rectus femoris. You can see the tendon is within the periphery at this level, and that originates from the anterior-inferior iliac spine and forms the quadriceps, part of the quadriceps muscles. Pectineus has got this distinctive shape within the anterior thigh, so if they show you that, it's quite straightforward. In terms of the adductor muscles, I think it's actually very difficult to test the adductor muscles and the short external rotators. There are a few which have, like I said, quite a distinctive look. Obturator internus has this 90-degree bend, and then the other ones, brevis is a small one anteriorly, just behind pectineus, magnus, and also longus. When you come further down, is a little bit smaller than magnus, which is a lot bigger. I think it'll be very difficult for them to show you some of the adductor muscle groups, but it is possible. And then you've got gracilis, which is a small muscle here. Moving on to the posterior, posterior compartment, you've got gluteus maximus, gluteus medius, and gluteus minimus. You can see that minimus, the tendon attaches to the greater trochanter, and then medius also here, this is the tendon, attaches to the greater trochanter. This is your ischial tuberosity, and these are your hamstring tendon origins. It will be tough for them to show you, but like I mentioned before, you need to know that the conjoint tendon of semitendinosus and the long head of the biceps femoris muscle is more medial, i.e. here, and then the proximal tendon of the semimembranosus is more lateral, which is just here. I think it'll be hard for them to show you or test you, but I think they could show you an image like this and then point to one of them, and you would have to say. So let's go through some of the bony anatomy on a pelvic X-ray. So starting from above, you've got the iliac crest, which is the superiormost part of the ilium. These are the sacral foramina of the sacrum. 4 is your sacroiliac joint. 5 is your anterior superior iliac spine. 6 is your anterior inferior iliac spine. Remember, your anterior inferior iliac spine is this tiny little protuberance here, which is actually just above this, which is actually part of your acetabulum. This is the superior acetabulum, and your aisis is just slightly above it. 7 is your iliopectineal line here. This is your ilioischial line. I'll show you another picture of it. 8 is your superior pubic ramus. 9 is your obturator foramen. 12 is your pubic symphysis. 11 is your ischial tuberosity. 10 is your inferior pubic ramus. On this side, you've got the femoral head, neck, lesser trochanter, greater trochanter, and 14 is just your femur. This is the intertrochanteric region as well. And depending on where people get, for example, proximal femoral fractures, the surgery differs. So this is the neck, intertrochanteric region, subtrochanteric region. These are some of the lines that they can test you on. This is your iliopectineal line. This is the one that curves around here and goes along the pubis. Your ilioischial line comes straight down along the ischium, and because this is the ischium, that's why it's the ilioischial line. Iliopectineal line, P is for pubis, so it sort of comes along the pubis. You've then got Shenton's line, which can be broken when people have neck or femur fractures. You then have the acetabular roof, the anterior and posterior edges of the acetabulum. I don't think they're going to test you on that. And then there's a little line here called the teardrop. I don't think they'll ask you what this, or that. Let's go through some cases now. So starting with A, you've got your anterior inferior iliac spine. Remember, that's above the acetabulum, and rectus femoris attaches to it. This is on the right, so say right in the exam. C is Shenton's line, which I mentioned can be broken in neck or femur fractures. Sometimes that's the only thing that you can see, and you can't actually see a fractured line. D is your acetabular roof, and then E is your left sacral ala. This is a pediatric X-ray. I mentioned this before, but your pubic bone and ischium in pediatric patients is attached by something called the ischiopubic synchondrosis. B is your left sacroiliac joint. C is your pubic symphysis. D is your acetabular angle. I don't think they're going to show it to you, but it's a line that you do to diagnose some diseases. E is your triradiate cartilage. This is an anterior view of it, and this is where the ischium, pubis, and ilium attach and create the acetabulum. So here, you've got this protuberance. This is called your ischial spine. So this is on the left. So this is your left ischial spine. B is your anterior superior iliac spine. C is your anterior inferior iliac spine. Actually, I think anterior inferior should be slightly lower around here. D is your left obturator foramen, and then what they're showing here is a line that's coming down along the ischium. So this will be your ilioischial line. So A, again, is your anterior inferior iliac spine, I think, is what they're also looking for. B is your left iliac crest. C is your obturator foramen, which the obturator nerve passes through. And then E is your lesser trochanter, which the iliopsoas tendon attaches to. And then D is your greater trochanter, which the gluteal muscles attach to, specifically minimus and medius. Let's go and do some MRI now. Starting with A, this is your ischial tuberosity. B is your right obturator internus muscle. As you can see here, it makes that sort of angle and attaches to this facet of the greater trochanter. C is your pubic symphysis. D is your right rectus femoris muscle. You know it's rectus femoris because sartorius is the most superficial, and you can see a little bit of tendon here, so this is rectus femoris, and then this would be your iliopsoas muscle. This and this would probably be part of your ilium and psoas major, making the iliopsoas tendon here. And then E would be, it's pointing out actually a nerve at this level. I think it's a little bit covered by the arrow, but this is your right sciatic nerve. I think I've got a better picture of it later. Yeah, so A is your right sciatic nerve here. You can see it's surrounded by fat, and if they point to a structure in the posterior thigh here, it would be your sciatic nerve. B is your obturator obturator nerve. That will exit through the obturator foramen. C is your iliopsoas muscle. That would be sartorius. Rectus femoris has that little bit of tendon, so then this would be your iliopsoas muscle. And then D here is a little bit of a curveball. This is your spermatic cord. Okay, so this will travel in the inguinal canal and then into the scrotum. And then E is your greater trochanter. So A is your hamstring tendon origin. I think that's the main thing that you need to say if they point to something which isn't the bone, which would be your ischial tuberosity, and it's just the tendon. B is your vastus lateralis muscle. It's starting to be, it's a little bit lower down in the leg, and so vastus lateralis starts around here. E is your tensor fascia lata. It's slightly speckled here. Actually, on the MRI, not sure if I showed you, but as you can see, tensor fascia lata has this sort of quite distinct speckled appearance to it, just because it's got a little bit of fat in it, and that's an easy way to find out what it is. And you can see here, it attaches to the iliotibial band. Okay, let's go through a few more. A is your right femoral artery. Remember, it goes nerve, artery, vein, nerve, artery, vein, and then here, and then, yeah, that's how navy, so nerve, artery, vein, and then a Y shape, which is more central. B is your obturator internus muscle. Remember that 90-degree attaching here. C is your ischial tuberosity. D is that tensor fascia lata, as I've just showed you, that speckled appearance. And then E, this is a little bit more sort of lower GI, but this is your right ischial anal fossa or fat. This is a lateral view of the pelvis and proximal femur. Remember, A is your iliacus muscle, which lies within this fossa made by the ilium, which is C. B is your big muscle of the buttock, which is your gluteus maximus muscle, and that's also slightly speckled, and that's the way of telling it apart from gluteus medius and minimus if it's otherwise difficult, but it's also the most superficial one, so that's the best way to remember it. D is your femoral head, and then E is your anterior labrum. So there's a black structure here, similar to your shoulder. You have a acetabular labrum, and that again deepens and helps with stability of the femoroacetabular joint. This is a coronal view. A is actually something called your ligamentum teres. This is your fovea capitis, which is a small indentation in the femoral head. And within that, there's a ligament which attaches to the inferior acetabulum. And that again helps with stability, but also does deliver some vessels and some nutrition to the femur. B is your labrum. Again, this would be your superior labrum. C is your gluteus medius tendon. It's quite difficult to say if it's minimus or medius, but because you're in the center of the femur, it's probably medius. And actually you can see it coming from this muscle here, which is your gluteus medius, and this would be minimus. And so you can see that black line attaching to the greater trochanter. D is your iliotibial band, and then lastly E is something called the transverse ligament of the hip. I haven't got a picture of it, but this goes from anterior to posterior and attaches to the acetabulum here, and again helps with stability. Coming further down in the thigh, we'll start with A. This is your rectus femoris. Remember, sartorius has already come down medially in the thigh at this point. So rectus femoris, and then these are your quadriceps muscles. So this is your vastus intermedius, which surrounds the femur. That's lateralis, that's medius. C is your sartorius, and then D would be your gracilis. Remember, try not to get them mixed up. They have a similar caliber, don't they? But sartorius is more superior than gracilis, is a good way to remember it. And then E is your semitendinosus muscle. Remember, membranosus is more medial than tendinosus in the upper thigh. And then this would be your biceps femoris muscle, the long head specifically. Again, let's reinforce some of these points. A is your sartorius. B is actually your long saphenous vein. Remember, your saphenous vein starts in the foot, comes up the entire leg medially and joins the femoral vein at the saphenofemoral junction. Remember, this is harvested for cabbage grafts. D is your right gracilis muscle. Remember, sartorius and then gracilis in the upper leg. E is your vastus medialis muscle, lateralis, medialis. And then C is your adductor longus. This is quite difficult to tell. I think it would be quite harsh if they showed it to you, but this would be adductor magnus because it's bigger. You're a little bit further down in the leg, and so it's probably not adductor brevis, which would attach quite high up. So this would be your longus, and then this would be your magnus. So you're starting to see some patterns, I hope. Let's do a couple more. They've cut off some of this, and so it's slightly harder to orientate yourself. So you've got to ask yourself, which one's this and which one's this? Remember, sartorius is more higher up than gracilis, which is this. And then B is your semitendinosus muscle, and then E is your right femur. Again, this is your femur, vastus lateralis, vastus intermedialis, vastus medialis, and then sartorius, gracilis, biceps femoris. Let's look at the knee now. We'll go through some bony anatomy first. The knee is made up of the femur, the tibia, the fibula, and the patellar bones. The femur, the more proximal part of the knee, the big part of this is called the femoral condyle. This is your medial femoral condyle, this is your lateral femoral condyle. Remember, this is lateral because the fibula is on this side, which is the bony protuberance you can feel at the lateral edge of your own knee. So 2 is your tibial spines or tibial eminences. This is where the cruciate ligaments attach, which I'll show you later. This is your tibiofemoral or femoral-tibial joint, or otherwise known as the medial compartment. People normally start to get arthritis in this area first because this is normally the weight-bearing area of the tibiofemoral joint. This is the lateral compartment. This is your tibia. This is your fibula. This is the styloid process of the fibula. This is your proximal tibiofibular joint. And then this is the lateral view of the knee. You've got your femur. You've got your patellofemoral joint. This is your patella. This is your tibial tuberosity, where your patellar tendon or ligament attaches, and kids can get that Osgood-Schlatter's disease, where this starts to, you get a traction apophysitis of it, and you can have some fragmentation here. And then this is something called the skyline view, where you see this patellofemoral joint a lot better. There are 2 facets of the patella, the medial and then the lateral facet. So this is the patella, this is the patellofemoral joint. This is your lateral patellofemoral joint, this is your medial patellofemoral joint. Then you've got a few, the knee has got lots and lots of ligaments, but for the part 1 exam, there's only a few that you actually need to know. So don't be intimidated when you open up a knee MRI or some of the other revision material that you might have. The ones that you need to know are your ACL, your PCL. These are your cruciate ligaments, and in the exam, make sure you say cruciate, not just ACL or PCL. The PCL starts from medial at the femur and then goes laterally. The ACL starts from lateral in the femur and then goes medially to attach to the tibia. I'll show it to you on an MRI. You then have your lateral collateral ligament and then your medial collateral ligament. Some people call it the tibial and then the fibular collateral ligament, but I think if you just call it the medial and lateral collateral ligament, that is what they want from you in the part 1 exam. And then you've got your medial and then your lateral meniscus as well. Again, there are muscles at the level of the knee and at the, within the shin. As you can see here, you've got sartorius. There's a group of tendons called the pes anserinus tendons. These are sartorius, gracilis, and semitendinosus, and they come medially and then attached to the tibia, just medial to the knee, and sometimes you can get some bursitis in that area that can cause pain. In the shin, the bulky anterior muscle just lateral to the tibia that you can feel is your tibialis anterior muscle. These are your dorsiflexors, so tibialis anterior. You've got your fibularis longus muscle, which is, your peroneus longus. Fibularis longus is an American term, but peroneus longus muscle, and then your extensor digitorum muscle as well. You've got your medial head of the gastrocnemius and then soleus muscle as well. Here you can see. This is the posterior view of the thigh. You've got your gastrocnemius muscle. You've got 2 heads. You've got the lateral and then the medial head. And then deep to this is your soleus muscle. And then these all join together into one tendon, which is your Achilles tendon or your calcaneal tendon. You can call it either or. This is a cross-sectional schematic of the knee. Your patella is held in place within the trochlear groove by lots and lots of mechanisms, but they can ask you about these 2. This is your lateral patellar retinaculum and this is your medial patellar retinaculum. You know your medial in the knee here because you can see this, which is your great saphenous vein. Also, the fat in the medial side of the knee is a little bit thicker than the lateral side of the knee, and so you've got to orientate yourself in the exam, see where you are, and the best way, and they will show it to you, they won't make it so hard that they won't show it to you, is by finding the great saphenous vein. Because we're medial, we know that the PCL or posterior cruciate ligament starts from medial and then goes lateral, and then the ACL starts from lateral and then goes medial. You've got some other muscles here, so you've got your gastrocnemius muscles here. You've also got your plantaris muscle here, which runs alongside the gastrocnemius muscles, and then the tendon also runs alongside the Achilles tendon as well. Further down in the leg, again, you've got your tibialis anterior muscle, your extensor digitorum longus muscle, and then your extensor hallucis longus muscle as well. You can see that tibialis anterior is the most medial, then extensor hallucis is after that, and then extensor digitorum is after that. And the way to remember that is Tom hates Dick, sort of like Tom, Dick, and Harry, which is an acronym which I'll show you for something else. The other one is Tom hates Dick, so tibialis anterior, extensor hallucis longus, and then extensor digitorum longus. Hallucis goes to the toe, digitorum goes to the other digits. And this is important at the level of the ankle, which I'll show you later. You then have your peroneal muscles or fibularis muscles. In the UK, we call them peroneal muscles. So peroneus longus, and there's also peroneus brevis, which I'll show you. Behind tibialis anterior, it stands to reason there's a tibialis posterior, which is immediately behind it. Behind that is your soleus muscle, and then behind that is your gastrocnemius muscle. I think the ones that they can show you them all, but the key ones would be tibialis anterior, soleus, which is deep to your gastrocnemius, and then you've got your medial and then your lateral head of the gastrocnemius. If they specifically show you the medial side and you can tell that it's the medial side, call it the medial head of the gastrocnemius muscle in the exam. This is further down, just above the ankle, I would guess. You still have some muscle bellies, but some of them, you can start to see the tendons. So again, Tom hates Dick, tibialis anterior, extensor hallucis longus, extensor digitorum longus. These are at the anterior shin, so these are your extensors is the way to remember it. And then you have your tibialis posterior, flexor digitorum longus, and then flexor hallucis longus. So this is your Tom, Dick, and Harry. And it's not just Tom, Dick, and Harry, it's Tom, Dick, and very nervous Harry. And very nervous is your veins and your nerves, and there's also an artery. And that's your neurovascular bundle. And again, that's important in the ankle. And then you've got your peroneal muscles and tendons, and then you've got your Achilles or calcaneal tendon as well. So let's go through an MRI of the knee. This is probably an MRI of the right knee because you can see the great saphenous vein here. There's another vein here, but yeah, these are just, sometimes you can have a few branches of the great saphenous vein. Also, the fat here is thicker than the fat on this side. That's another way of telling what side you're on. Starting superiorly, you've got your quadriceps tendon, which goes into the patellar bone, which then goes into the patellar tendon or ligament. You call it either or. Remember, the patella is stabilized within the trochlear groove by the medial and lateral patella retinacula. These have multiple attachment sites, which you don't need to know. But again, these stabilize the patella at the patellofemoral joint. You have this intermediate signal, cartilage at the back of the patella. This is your retropatellar cartilage. And also you've got this cartilage in the trochlear groove. And remember, you've got cartilage in all your joints. On x-rays, you can't see them, but on MRIs you can. Remember, on x-rays, when people have changes of osteoarthritis, they get narrowing of the bones. That just means that the cartilage is worn down, and so the bones are next to each other. That's just the x-ray equivalent to what you might otherwise just see as cartilage damage on an MRI. On these axial views, again, medially, you've got these tendons here, which are your pes anserinus tendons, which would attach to your tibia here. Again, that's your sartorius, gracilis, and semitendinosus. It goes in that order. The way to remember it is say grace before T, so sartorius, gracilis, semitendinosus, and those constitute your pes anserinus tendons. Sometimes you can get something called pes anserinus bursitis, where there's a little bit of irritation, which can be painful. This is your iliotibial tract, and that attaches here on the tibia. You then have your popliteus tendon, which I think is one of the tendons which is a little bit harder to appreciate, but they can ask you about. That's on the lateral side of the knee. So this is your popliteus tendon. It attaches to the lateral femoral condyle in the popliteus groove, and then comes down here behind the knee, here, and then this is the popliteus muscle here. This muscle and tendon help stabilize the knee in full extension and help lock the knee. So that's what it does. Up here, you've got your gastrocnemius muscles, which sort of originate from the distal femur. And that's the main anatomy on the axial images. Let's go to the sagittal images. Again, you've got cartilage between the femur and the tibia. That's this intermediate signal on the femoral and the tibial articulations. Again, when this is damaged, the knee joint space is narrowed. This black structure here, which looks like a bow tie, this is a meniscus, and you've got to ask yourself, is this the medial or lateral meniscus? You can't see the tibia here, which I'll show you later, and so this is probably the medial tibial plateau. Also, it sort of looks like a golf tee. It's got a little bit of an indentation here compared to the lateral tibial plateau, which I'll show you, and so this would be the medial meniscus. And the meniscus is made out of the body, the anterior and posterior horns, and then the roots as well. I think they'll probably show you the anterior, posterior horns, or the body. All these other ligaments you probably don't need to know for the exam. On this side, you've got the lateral tibial plateau. You can see it's not as concave as the other side. It's a little bit flatter, not really like a golf tee. And also you've got the fibula here, and so you know you're on the lateral side. So this would be the lateral meniscus, the anterior and posterior horns. Here you've got two structures. These are your collateral ligaments, your cruciate ligaments. This is your PCL, which goes from sort of the femur posteriorly, so posterior cruciate ligament, and then this is your ACL, which goes from the femur anteriorly, so your anterior cruciate ligament. And a really easy way to tell them apart from their orientation, is actually their signal. The PCL is always going to be the darker one, and your ACL is always this intermediate signal heterogeneous structure. And so in the pressure of the exam, if you can't tell which one's which, on the sagittal you'll be able to, but on the axial you might not be able to tell which one's which. For example, here, if they don't show you the fibula, maybe on a slice like this, you don't know which one's which, just remember the darker one will be your PCL. Okay, and remember PCL starts from medial and then goes laterally to attach to the lateral tibial eminence, and then the ACL goes from lateral to then attach medially onto the tibia. You then medially have your MCL, so medial collateral ligament, and then laterally you have your LCL, or your lateral collateral ligament. This, just for your information, joins with the long-headed biceps femoris tendon to create the conjoint tendon, which then attaches to the fibula. This area is really, really complex, and there's a lot of anatomy, but just the things I've mentioned are probably the ones that you need to know for the exam. Remember, you can see the menisci on the coronal images as well. This is a meniscus, and then this is a meniscus. This is your lateral, this is your medial. If they point to this, say the body. If they point, for example, here, this is actually the anterior horn, and then back here is your posterior horn. I think it would be difficult if they showed you this and said, try to make you say which horn it is. I think if you just say medial or lateral meniscus, if in doubt, you should get it correct. And then again, this is the articular cartilage between the two bones. Let's look at some cases. So this is a X-ray. It's been labeled left, so you have to say left in the exam. A is your lateral femoral epicondyle. This entire thing is the condyle. This small protuberance is the epicondyle. This is an epicondyle as well. C is your popliteal groove. This is where your popliteus tendon originates. Remember, you're on the lateral side. B is your medial tibiofemoral compartment or medial compartment. D is your medial tibial spine or medial tibial eminence as well. Okay, and E, they've drawn around this structure here, which is your patellar bone. Okay, so this is a lateral view of the knee. They've pointed to the femur on A and B. The medial femoral condyle is larger than the lateral femoral condyle. It's actually sometimes quite difficult to say which is which when you actually get lateral knee radiographs in real life, just because of the way that if it's taken in a certain way, it's actually sometimes impossible to tell. But in the exam, if they show you one, and they specifically point to one. If it's the bigger one, say that it's the medial femoral condyle. If it's the smaller one, say that it's lateral. And C, they've pointed to the intercondylar groove, which is made up of that space between the femoral condyles, where on an X-ray you can just see this line like this. D is your tibial tuberosity. Remember, Osgood-Schlatter's disease in kids affects this. And then E is the diaphysis of the fibula. Again, a lateral view of the knee. A is your proximal tibiofemoral joint. Remember, you've got a distal one at the ankle. B is your patella. C is a fat pad. So this is your infrapatellar or Hoffer's fat pad. You can call it either or. There are a few eponymous names for fat pads. There's Hoffer's, there's Kager's in the ankle. If you just describe where it is, infrapatellar fat pad, I think that's the easier way to do it, and you will definitely get marks. E is your tibial tuberosity. Remember, this structure here is your patellar tendon, which you can make out on an X-ray, which attaches there. And then D, obviously, is your femoral diaphysis. A is the styloid process of the fibula. It's pointing to this specifically, which is your styloid process. B is your patellar tendon. It's pointing to this structure here, which is attaching down here. E is your infrapatellar fat pad or Hoffer's fat pad. D is your patella. And C is something called a fibella. This is a sesamoid bone, which is embedded in some people within the lateral head of the gastrocnemius muscle. Let's go through this. So we know we're lateral because we can see the fibula here. And as you can see, this is also a little bit flatter than that golf tee shaped medial tibial plateau. So A is your lateral tibial plateau. Okay. B is the posterior horn of the lateral meniscus. C is your quadriceps tendon. D is the articular cartilage of the lateral femoral condyle. You can see this intermediate signal thing that overlies the cortical bone, so that's cartilage. And then E is your the head of your fibula. So we're at the level of the femur. There's only one bone here, so we're just above the knee. So this would be your femur. A would be your. We've got to orientate ourselves. So where are we? Is this medial or is this lateral? This is thicker than this, and also there's a vessel here, so this would be medial. So laterally in the lower leg, you've got your biceps femoris muscle, and you can start to see the tendon forming here. B is your quadriceps tendon or expansion, I would call it a tendon in the exam. D is your femur. C is your sartorius muscle. It's starting to form the distal to this, or start to form the peds anserinus tendons. These are the neurovascular structures just behind the knee. So these are your popliteal veins and arteries. The vein is larger and more superficial than the artery, which is deeper. The way someone told me it was, if you injured the back of your knee, I don't know, if you got cut at the back of your knee, your artery is slightly protected because it is deeper to the vein. This is an X-ray, sorry, a CT. You can still make out lots of structures here, right? So you need to orientate yourself. You can see this is a vessel here, and also the fat is thicker here. So this is medial, this is lateral. They're therefore pointing to the medial patellar facet, and then this is the lateral patellar facet. D would be the medial patellofemoral or medial, patellofemoral retinaculum, or just medial patellar retinaculum. B would be your medial femoral condyle, and then E would be your intercondylar notch. That's what this is, where the cruciate tendons sit and originate. This one's straightforward. This is lateral, this is medial. So this is your medial collateral ligament. This is a pediatric case. You can see that the growth plates have not fused. A is your quadriceps tendon. B is your patellar tendon. C is your infrapatellar or Hoffer's fat pad. D is the posterior horn of the lateral meniscus. And then E is your popliteus tendon. This is something that they can show you. Clinically, it's actually a really important area. Injuries here can cause a lot of knee instability. And so behind the lateral meniscus, if they point to a structure, assume it's going to be the popliteus tendon that you're just catching on a sagittal view. I don't think there's any great way to remember that, but they do sometimes like showing it. Okay, so they've shown some structures here laterally. You've got the fibula here, and so you've got to ask yourself, what is the structure coming from the lateral thigh down to the fibula, or even just down laterally, and that is your iliotibial tract. Remember, runners can get some sort of issues with this, and like some friction that can cause pain. Deep to that is your lateral collateral ligament or your fibular collateral ligament. You can call it either or. C is actually your popliteus tendon. You can see your popliteus groove here, and then the tendon is coming just from that. It's not pointing to the meniscus or the lateral meniscus. It's pointing to this black structure here, which is a bit more round, which is your popliteus tendon. D, you're going to ask yourself, is this the anterior or posterior cruciate ligament? It's darker. It's coming from medial, and so this is your PCL or posterior cruciate ligament. And then E would be your medial meniscus. Again, head of the fibula, medial femoral condyle, lateral or fibular collateral ligament, medial meniscus, and then you've got to ask yourself, is this the posterior or anterior cruciate ligament? It's darker, it's coming from medial, so it's the PCL, and then these would be some fibers from the ACL. Okay, we'll go through a few more. Quickly, PCL, darker, ACL, more heterogeneous, retropatellar cartilage, patellar tendon, tibial tuberosity. This is medial. It's a bit thicker here. You can't see the fibula, and so that's why it's quite tough, isn't it? And so this fat is thicker than that fat, and that's the way to orientate yourself in this one. You can't actually see the vessel on this slice. So this would be your medial collateral ligament. B would be your PCL, it's coming from medial and then going laterally, and then this would be your ACL coming from lateral going medially, and then C would be your iliotibial band. D would be the articular cartilage of the medial tibial plateau. This is the tibial articular cartilage, this is the femoral articular cartilage. This is your patella, this is your great saphenous vein. This would be your sartorius muscle. You can still see some muscle here. And remember, that's that super long muscle that crosses two joints, the hip and the knee. And you can see that here. Because this is medial, this would be the medial head of the gastrocnemius muscle. And then 99 would be your lateral condyle, lateral femoral condyle. A is your ACL. You see it's a bit more heterogeneous. And then it's coming from lateral to medial. This is thicker than that. This would be your PCL. C would therefore be your medial collateral ligament. This would be your lateral meniscus and lateral femoral condyle. Okay. This is lower, just below the knee, and it's pointing to some muscles here. The most anterior muscle in the shin would be your tibialis anterior. Just behind that is your tibialis posterior. This is the originate where your flexor hallucis longus muscle sort of starts, and then you see it in the ankle. I think if they showed you this, it'd actually be very difficult, but that's what this is. This is your soleus, which is deep to your gastrocnemius muscle. Then last one in the knee, tibia, fibula, this one's bigger than that. This is your tibialis anterior, and then E would be your tibialis posterior. Let's now look at the ankle and foot. So this is at the level of the ankle. This is this is medial, this is lateral. Sorry, this is medial, this is lateral. So medially anterior, in the anterior ankle, you've got your tibialis anterior, you've got your extensor hallucis longus and extensor digitorum longus. So this is the Tom Hates Dick tendons, and I'll just show you a cross section of this and point to one. In the posterior medial ankle, you've got your tibialis posterior, flexor digitorum longus, and flexor hallucis longus, which is this. You can see some of the muscle belly in this one. And this is Tom, Dick, and very nervous Harry. These are your neurovascular structures here. And then in the lateral ankle, you've got your peroneal tendons. You've got brevis and longus. Remember, brevis is closer to bone, and that's the way to tell them apart when they're not labeled like this. And then back here, you've got your Achilles tendon, and then also your plantaris tendon as well. Let's look at an X-ray, a labeled X-ray, anterior view, lateral view. This is your fibula. Remember, the distal part of your fibula is called your lateral malleolus, and the distal part of your tibia, the most medial distal part, is your medial malleolus. The bone that these articulate with is your talus. This is a lateral view. This is your talus again. Your heel is your calcaneus. 11 is the posterior talar process. Sometimes you get a little ossicle here, and that's called your os trigonum. Sometimes this can be elongated, and that's called a steator process. The bone that the talus articulates with is the navicular, which is this as well. There are lots of ligaments in the ankle and foot. You don't need to know them all. Most people don't need to know them all, but there are a few you should know. In the upper ankle, you've got your tibiofibular ligaments. That goes from your distal tibia to your fibula, and again, you've got anterior and posterior ones. You then have ankle tendons between the fibula and the talus. These are your talofibular ligaments, and these are the ones that are typically sprained when you sprain your ankle. You've got your anterior talofibular ligament, your posterior talofibular ligament from the talus to the fibula, and then you've got your calcaneofibular ligament from your calcaneus to your fibula. The one that actually sprains the most is your ATFL, or anterior talofibular ligament, then the CFL, and then the PTFL doesn't really get injured unless it's a very bad injury. This is an axial view in the upper ankle. So this is your anterior tibiofibular and posterior tibiofibular ligaments. When someone says that you've got a high ankle sprain, these are the things that get injured. This is an anterior view, and these are the muscles and the tendons. So medially, you've got your tibialis anterior, extensor hallucis longus. Remember, Tom hates dick, and then extensor digitorum. Hallucis is hallucis because it goes down to the toe. So you can see this muscle and then tendon going down to the big toe. And then digitorum, it has a common tendon sheath, and then they split into the extensor tendons of the remainder of the toes. On this, I just wanted to show you your plantar fascia or plantar aponeurosis. That goes from the heel and then extends towards the digits. Really important in stability. When people get plantar fasciitis, it typically starts here, and there's inflammation here. They do like showing abductor hallucis sometimes, and then you've got abductor digiti minimi, which is lateral. Sometimes you get something called Baxter's neuropathy, and then this can be affected by that. Let's look at some MRI. So this is an MRI of the ankle. You've got to ask yourself, first of all, where's medial, where's lateral? This is medial, this is lateral. This is the tibia, this is the fibula. This is your ATFL, anterior talofibular ligament. This is your PTFL, posterior talofibular ligament. It's sometimes quite hard to see. Then on the medial side, you've got your deltoid ligament, and I'll show you that on a better view. in the anterior ankle, you've got your Tom, Haight, Dick. So tibialis anterior, extensor hallucis longus, extensor digitorum longus. The posterior medial ankle, you've got your tibialis posterior, flexor digitorum longus, and flexor hallucis longus as well. And then you've got your neurovascular bundle with your tibial nerve and then the vein and artery here. As you can see here, you've got your soleus muscle. You can't see your gastrocnemius muscle at this level. These both fuse into your Achilles tendon or calcaneal tendon. And then you've got your peroneus tendons here as well. Remember, brevis is close to bone. Brevis attaches to the base of the fifth metatarsal, and you can get an avulsion fracture there. So that's the base of the fifth metatarsal, which the tendon of extensor peroneus brevis attaches to. The other thing to know about in terms of the bones, you've got your sustentacnum talus, which is this medial ridge of the talus as well, and then you also have an osseous tunnel, which is really important in the foot between your talus and your calcaneus. This is called your sinus tarsi, yeah, it's an important structure, but it just looks like a tunnel here. There's just fat in between the two here, and there's a few ligaments too. On the sagittal view, you can see the Achilles tendon here. This would be a soleus muscle. This would be the dome of the talus. And then there's lots of different processes that you probably don't need to know in the exam. In terms of bones of the foot, after your talus, you've got your navicular, and then you've got these, which are your cuneiforms, and then your cuboid. In terms of your cuneiforms, you've got your medial, you've got your intermediate, and then you've got your lateral cuneiforms, and then lateral to the lateral cuneiform, you've got your cuboid bone as well. Yeah, these are your tarsal bones, and then attached to them are your metatarsal bones. And this area here is an area where you get a Lisfranc injury. I won't get into that, but this is why this area is important. Between the base of your second metatarsal and your medial cuneiform, that's the most important part. Let's look at the forefoot. There's not much they can ask you in this. This has similar bony structures to the hand, but instead of metacarpals, you've got metatarsals. Then you've got your phalanges as well. I think the best thing to do would just be to look at some cases now. So this is a right foot radiograph. This is an oblique view. You've got your talus here. The bone that articulates with that is your navicular. It's pointing to a bone in your, just medial to your cuboid bone, and so that's your lateral cuneiform. Here it's pointing to the base of the fifth metatarsal. You can call it a tuberosity or base of the fifth metatarsal. You then have some sesamoid bones in your big toe. The sesamoids run in tendons of the flexor hallucis brevis tendon. You've got a medial and lateral sesamoid, and the medial head of flexor hallucis brevis and lateral head of the flexor hallucis brevis pass through their respective sesamoid bones. And then 5 would be the proximal phalanx of the right second toe. A would be, so this is the left side, A would be your cuboid. You've got your medial, your intermediate and lateral cuneiforms. You've got your metatarsals, this would be your the fourth, and then it's pointing to the sesamoid bones here, which I've just mentioned, and then E would be the middle phalanx of the fourth toe. A is the proximal phalanx of the little or fifth toe. B is the sesamoid bone, which you can see. C is the lateral cuneiform, because this is the cuboid, so this would have to be a cuneiform. D, they've pointed to an accessory bone here. This is your os perineum. This is a sesamoid bone as well, which you sometimes see in some people. The tendon that this passes through is the peroneus longus tendon. And yeah, they can show it to you like this. And then E is your talonavicular joint. If they're showing you pointing to the line, you have to say that's the joint. So talus and navicular, so talonavicular joint. This is a pediatric case because the growth plates haven't fused. this is your talar dome. This is quite important when it comes to injuries. You can get sort of little fractures and little lesions. They're called osteochondral lesions, and so that's why this is important. And this should be nice and smooth like it is here. This is your talar dome, and then it's trying to ask you which bones are these. The talus articulates with the navicular, and so that's why this will be the navicular. And then the navicular medially articulates with the medial cuneiform, so that's what that is. Another pediatric case. It's pointing to the distal fibula here. B would be the talus. C, this sort of like thin structure here, would be your navicular. D is your cuboid. It's the lateralmost bone in the foot, and it's got the shape of a cuboid, and the cuboid is a big bone as well, and so that's why that's the cuboid. And E is the base of the fifth metatarsal. Again, your heel is called your calcaneum. This is the head of the talus. I think if you say talus, that's fine as well. This is your navicular. D is the calcaneal cuboid joint. So the joint between the calcaneus and cuboid will be the calcaneo-cuboid joint. And then again, they like asking about the base of the fifth metatarsal because it's clinically quite important when it comes to fractures there. They're asking you to name the normal variant here. And that's this structure here. This is an os navicular. This is a os naviculare. This is a navicular, and this is an os naviculare. These are the sort of images they can show you of the tendons. Okay, this is your tibia, this is your fibula, and so medial, lateral. So Tom hates Dick, tibialis anterior, extensor hallucis longus. Extensor digitorum as well. Then medially, tibialis posterior, so Tom, Dick, very nervous, Harry. Tibialis posterior, flexor digitorum longus, flexor hallucis longus. Again, A, they're pointing to this tunnel here. This is your sinus tarsae, which I mentioned. C is where your plantar fascia attaches. So on the MRI, that would be this. So this is your plantar fascia, which attaches to your calcaneus here. And then, you get inflammation at this level when you've got plantar fasciitis. D is your calcaneum. E is your Achilles tendon. And then B, the first bone that articulates with the talus, is your navicular. We've spoken about a few of these. Remember, Tom hates Dick, Tom, Dick, and Harry. These are your peroneal tendons. This flat one, which is closer to the bone, is brevis, and then so the other one would be longus. On this image, I want to show you the medial ankle ligaments. These are your deltoid ligaments, and just know that there's a deep and superficial deltoid ligament. There's a bit more complexity to it, but you don't need to know that for the exam. D would be your deep deltoid ligaments, and E would be your superficial deltoid ligaments. And then you've got other ones as well, which are clinically important, but I don't think they'll test you. This structure here, because it's medial, this is your sustentactinum talus, which they can test you. And then this, this is your actual talus. That's your lateral malleolus. And then C is your abductor hallucis muscle, which they sometimes like to test you on, and that's this medial muscle here in the foot. So this is your talus, this is the head, this is the neck, and then this would be the body. It is split up like that. I think in the exam, if it's pointing obviously to part of it, then say it, but otherwise talus should normally be okay. This is your navicular. This is probably quite medial in it, so this would be, actually, I don't think you can tell exactly where you are in this one, and so I would just say this is the base of a metatarsal, and then this is the head. We've gone through these structures. So A, again, this is your deltoid ligament. These would be your deep deltoid ligaments. This would be your superficial deltoid ligament. B, they're pointing to the tibialis posterior tendon. I think that's really hard to tell on this. E is your sustentachinum tali, which is part of your calcaneus and not your talus, remember that. It's a really important structure, and they do like testing it. The structure between the two on this coronal, this would be a coronal view of your sinus tarsi here. And then C and D, these are your flexor hallucis and flexor digitorum tendons. I think it's really hard to show in the exam. This is an example. I think it'd be quite hard if they showed it to you in this. So orientate ourselves, what's medial, what's lateral. See, they're actually pointing to the long saphenous or great saphenous vein. Remember, it actually starts in the ankle and goes all the way up. So Tom, Dick, and Harry, tibialis posterior, flexor digitorum longus, flexor hallucis longus. And then you've got your perineal tendons here, brevis is closer to the bone, and then longus here. Just a few things on this. There is a ligament that goes between the talus and calcaneus in the sinus tarsi. This is called the interosseous ligament, interosseous talo calcaneal ligament. And yeah, that's what that is. A is the deep part of your deltoid ligament. Actually, that would be a little bit more up here, but yeah, this is pointing to that. Superficial will be here. E is your peroneus longus tendon. Again, it's quite hard to tell, but this would be the brevis tendon, which is closer to bone, and then this would be longus. And then C is your talofibular joint. Remember, the fibula and the talus have an articulation, so talofibular joint. This is in the foot, and a few key structures to remember. Remember, you've got your sesamoid bones. This is what it looks like on the MRI. Remember, your sesamoids run through the flexor hallucis brevis tendon. This is medial, this is lateral, because the toes are lateral to the big toe. So yeah, medial head and lateral head of the flexor hallucis brevis tendons. That's what they run through. B is your flexor hallucis longus tendon, which runs through and then attaches to the big toe, and that passes between the two sesamoid bones. See, if they show you a muscle here, just say it's an interosseous muscle. And then this is part of your plantar fascia here. This is going towards the toes. And then D is your extensor hallucis longus tendon here. Lastly, I'm going to talk about pediatric hip ultrasound. This can be quite intimidating, but there's only a few things that they can show you. This is a picture of the hip, and I've drawn an ultrasound probe here and then the ultrasound beam here. When they scan these hips to look for hip dysplasia, this is how they do it. They get the neonate or baby on the side, and they scan it like this. And so you see the femur like this, and then you get an image like this. There's only a few things on this that you need to know, and they are highlighted here. You've got your acetabulum here, you've got your bony acetabulum here, you've got your cartilaginous acetabulum and your labrum here, and this is what the femoral head looks like. The femoral head is unossified, and so that's why you don't do an x-ray for these in babies, because it's unossified, you won't be able to see it. But part of the ilium is ossified, and so that's why the ultrasound beams can't penetrate it. This is a bit more detailed. So you've got your ilium here, you've got your bony acetabulum, you've got your cartilaginous acetabulum and your labrum here, your femoral head. Some of these other things they won't ask you about. Your triradiate cartilage here is between the ilium and pubis, which is you can see on this slice. This is really high resolution. You can even see your gluteus minimus and medius tendons, but they won't ask you about that in the exam. There are a few angles that you should be aware of, which they can ask you in the exam. And this is where femoral acetabular dysplasia, this is how it's diagnosed. The alpha angle is between the ilium and then your bony acetabulum like this. This should be above 60 degrees. If it's shallower, you can imagine that the femoral head is slipping out a little bit more, and that would put them at risk of instability and acetabular dysplasia. You also have something called your beta angle, which is the angle made here, and that should be less than 77. Again, you can see that this is the bony acetabulum, this is your cartilaginous acetabulum, and your labrum here. Let's go through an example. So orientation, this is your ilium, bony acetabulum, so that's what E is, your osseous or bony acetabulum. D would be your cartilaginous acetabulum. C is the angle made with the beta angle. B is your alpha angle, and then A is your femoral head. And then that's the end of it. I hope that was helpful.